Hello, and thank you for your interest in total hip arthroplasty. I use a minimally invasive technique. The purpose of this is so that patients have less pain and are up and going much more quickly after minimally invasive hip replacement surgery than they are after conventional or other forms of hip replacement surgery. I prepared this tape to answer many of the frequently asked questions about hip replacement and to give a bit of an introduction to the whole process so that you're entirely familiar with the procedure. The first question, I suppose, is what is a total hip arthroplasty? Well, to start to answer that, one first has to ask, what is arthritis? And hip arthroplasty is done as a treatment for end-stage arthritis. Now, of course, arthritis comes in many forms. There's traumatic arthritis, osteoarthritis, rheumatoid arthritis, and many others. But they have a common end point where the joint is largely destroyed. The patient has pain, limited capacity to walk, and pain with motion. And at this point in time, at least, and probably for the next 10 to 20 years, the best option for patients who are debilitated on the basis of arthritis in the hip is hip replacement. So the question then becomes, what is arthritis? Well, arthritis is loss of the articular cartilage, or the surface covering on the end of the bone. If one thinks about the white on the end of a chicken bone, this is also cartilage. Cartilage allows the one bone to move on the other in a smooth and even fashion. Cartilage also absorbs some of the shock of ordinary activities such as walking or running. Now, in a normal person, the friction between two healthy articular surfaces is much less than the friction of ice upon ice. On the other hand, the friction between the two surfaces in our arthritic joint may be much more like sandpaper on sandpaper, and when one hits bone on bone, this hurts. Now, the hip itself is a ball and socket joint. The problem where most people, at least that I see develop arthritis, has to do with the hip not being normally formed sometime during growth. Now, there are many different developmental abnormalities, but the most common is that the hip is not entirely round or is not centered on its stem or stick, so to speak. Again, the normal femur is a bit like a lollipop with a round head centered on a stick. And if the head isn't round or it's not centered, then sometimes the out of round head tries to fit into a round socket. And if you imagine trying to take an egg and put it through a circular hole, in some directions it fits very nicely. In some directions it just doesn't fit, and if you try too hard, eventually the egg breaks. Well, the hip doesn't, this isn't the cause for hip fractures, but if the oblong hip is put into a round circle, it overloads the cartilage and eventually the cartilage wears away. So the purpose for doing a hip replacement surgery is to first relieve pain and subsequently to improve function, improve motion, and improve the quality of the life of the patient who has the hip replacement surgery. Overall, somewhere around 95% of people will have a good or an excellent result. Now, I think the term excellent speaks for itself, and so people who have excellent results know exactly what that is. A good result can be defined as somebody who has no more than occasional minor discomfort, occasional minor stiffness, and is able to do pretty much anything that they'd like to do. Now, common questions about hip replacement surgery. Probably the most common question that I'm asked is, after the surgery, when can I drive? This is a very complicated question. If one thinks about it, there are probably many people on the road right now driving who have no business being on the road, and they haven't had any sort of significant surgery recently. Safe driving is more than just reaction times. It is also concentration. It is also ability to recognize problems. And more than anything else, it's the ability to handle emergencies. And so the question of driving is not whether one can get from your house to the corner store or to a friend's house around the block. The question is if one can deal with emergencies. And emergencies happen close to home. It's your next door neighbor's kid who will run into the street in front of your car. Will you think for a second about your hip before you hit the brake? And if so, I don't want you driving at all, whether it's around the corner or to California. There's really very little in the way of scientific evidence to answer the question, And what little scientific evidence there is talks about reaction times only. These are really pretty primitive studies, but they suggest that it's 6 full weeks from the time of any hip surgery until the time that one can safely drive. And it didn't matter if it was the right hip or the left hip. Now, of course, these studies are not done with MIS technique, and they are very simplistic, looking only at reaction times. But right now, that's the only data that there is in the literature. So if one wants my blessing on driving, I have to say 6 weeks. On the other hand, I would hope that my patients are responsible adults. And if they can honestly answer the question that they're not going to think for a second or a fraction of a second about their hip before they react to an emergency, then go ahead and drive. Now, I've had a patient admit to driving as little as 4 days after hip replacement surgery.
Correction, now 2 days post-op.
And again, this is a patient admitting it may have been done sooner, and it's not necessarily with my blessing, but I hope that you understand the importance of being able to manage emergencies. And if you can do that, enjoy, go ahead. If you can't do that, or if there's any question, then please ask somebody else to drive. Another common question that I'm asked, how long will the hip replacement last? Well, this also brings into question the concept of different bearing materials, and this is something that is very popular in the press these days. Unfortunately, there's a great deal more information in the popular press than there is real information or scientific data to support it. Metal on plastic has been the bearing surface pretty much since the invention of total hip replacements in the late 1950s, early 1960s. It is to some extent the devil we know rather than the devil that we don't know. And the modern plastics that are available today seem to be much better and perform much better than those that were available many years ago. So while the previous generation of plastics would last about 10 years, if one really believes the bench data, the current generation is likely to last somewhere around 30 years. I don't think that any surgeons are quite that optimistic, but 15 to 20 years is a good expected survivorship for the current state-of-the-art metal on plastic. Metal on metal and ceramic on ceramic also are being promoted these days. I have a problem to some extent today with the ceramic on ceramic bearings.
I interrupt this broadcast for a clinical update. The major problem with ceramic on ceramic is so-called stripe wear. This gives rise to a high friction bearing and frequent squeaking. Both of these are bad.
Squeaking is caused by friction. That can't be good. And metal on metal bearings also are being promoted. One potential advantage of metal on metal bearings is that one can use a larger head and diminish the risk of dislocation. So the risk of dislocation is small with an experienced surgeon. It is never zero, even with the metal hips. The metal on metal hips are much more expensive, and they also generate a great deal of metal ions. Metals such as chromium and nickel are potentially carcinogenic. And the bottom line is, at least right now, I'm not particularly comfortable with metal on metal, though I look at it frequently.
I interrupt this broadcast for another clinical update. Large ceramic femoral heads on plastic is a reasonable option.
Another question that I'm asked is, how much will this hurt? Well, the whole point of the minimally invasive surgery is that it hurts less. Part of the discomfort after the hip replacement seems to come from the abnormal positioning that's done during the replacement, and much greater twisting and torquing and pulling is required during conventional hip replacement than is required during the minimally invasive approach. Additionally, no muscles are detached from their origin, so on the way out, there's no repair that's necessary, and therefore, after the surgery, there's no protection of the repair that's necessary. Now, let me translate that into more practical terms. After a conventional hip replacement, usually weight bearing is restricted and the patient is required to walk with crutches or a walker for as long as 6 weeks. If everything goes according to plan with the minimally invasive hip replacement, patients are allowed to put as much weight as they feel comfortable on the hip immediately. Now, this means that most people will still use supportive devices, but the time is usually measured in days rather than in weeks or months. Most people will complain about soreness more so than pain after this replacement. This type of soreness that one might have after working out a little bit too hard. because in fact I do have to pull on the muscles, and that stretch is sometimes felt as soreness or tightness in the muscles after the surgery. Again, a great deal less discomfort. The vast majority of patients will come in for their 2-week visit without using supportive devices. Another question that I'm frequently asked, how long does the surgery take? Well, to some extent I find this a bit of an odd question, as it's usually coming from the patient and they're going to be asleep. To them it might seem like it's 5 minutes. But for the family members who are waiting, my time, the surgical time, is somewhere around 2 hours. I keep track of how long it takes so that I can say most of my cases are done between about 90 minutes and about 130 minutes, an hour and a half to about 2 hours. I don't do this for time. I spend as much time or as little time as is requisite to get each individual hip right. And some patients just take a little longer, some patients don't take quite as long. The bottom line is I don't leave the operating room until I'm happy. Now, in addition to my time, though, your family will be waiting for the anesthesiologist to put you to sleep, for the surgical team to get the patient positioned, prepped, and draped, and then the surgical time starts. So more or less you can count on somewhere around 3 hours of waiting time between when you say goodbye to the patient in the holding area and I come out and talk to the family while anesthesia is waking the patient up. Another question that comes up has to do with discharge plans. It seems that there are some surgeons who view the hip replacement patient as an ingredient in their recipe for hip replacement. Instead, I view that the patient is the main course, and it's my goal to be sure that everything goes together very well. To this extent, most of my patients will go home. And the last time that I calculated my statistics, 98% of people who were under 80 years of age went directly home from the hospital after an average stay of about 2 nights. Those over 80, about 50%, weren't safe to go home to their home environment, and so they required a rehabilitation stay at a standard rehabilitation hospital. Now, I don't know how to overemphasize this point. Where the patient goes after the hospital stay is what fits the patient best. How long they stay in the hospital is what's requisite for them to stay. I keep my statistics so that I know the answer and can answer the question, but each individual patient has their stay and their treatment tailored to their needs. Now let me give you an example about discharge planning. These are 2 real examples. I have one patient in my practice who has a daughter who's a physical therapist, lives in a 1-story house, has no steps, no obstacles. There are gobs of family and friends both willing and able to take time off to assist, and they live near an outpatient physical therapy setting. This patient can go home pretty quickly. On the other hand, I also take care of some elderly patients who live by themselves, have generally been the caretakers of their elderly and less well friends. They have no friends or family in town who could care for them, and they sometimes have as much as 30 steps to their front door. These people can't be treated in the same manner when you talk about discharge plans. The first patient is very likely to go home very shortly after the surgery. The second patient is going to need a little longer hospital stay and more likely than not a stay in a rehabilitation center. To make this almost too simplistic, if there were a fire in the house and you were at home and you couldn't get your own body out of the house safely, you're not safe to go home. And so it doesn't matter if the spouse is much bigger and stronger than the patient or the spouse is smaller. The patient has to be relatively independent. And again, for most patients, this happens around 2 nights in the hospital. People are ready then to go home. I have another reason for preferring that patients go home. In a sense, when you go home, you're not going to ask your friend, your family, your spouse, your kids to get every drink of water, to bring you the bedpan, to clean the bedside commode. Instead, you're going to get up at least some of the time, go to the kitchen to get the glass of water, and you're going to get up in the middle of the night and walk to the bathroom. This is also therapy. If you're in a rehabilitation center and you're thirsty, what do? You hit the button, the nurse comes and brings you a drink. You know, it's different. And while you don't have the structured exercise at home, people do seem to be and do better at home and in their own home environment. And many studies have shown that people need and use less pain medicine if they're in their own home environment. Every surgery has risks and potential complications. Every activity we do has risks and potential complications, even things as simple as crossing the street. But like crossing the street, if you keep your eyes open and you watch what you're doing, the chance of having a problem is really pretty small. That having been said, it's my obligation to say that the risks of any surgery include bleeding, infection, failure to achieve the desired goals, persistent pain, need for further surgery. And while the list can continue, I'll come back to where I started and say that around 95% of people will have good or excellent results, and the chance of there being a significant complication is really quite small. One specific minor complication that is sometimes seen with this particular surgery has to do with a small sensory nerve that is near where one of the incisions is made. This nerve is called the lateral femoral cutaneous nerve. Now, while it's not rare, it is also not common for this nerve to be stretched a little bit during the course of the surgery, and this will result in a little bit of numbness along the outer edge of the upper thigh. In the vast majority of patients, this resolves over the course of a relatively short period of time, and it has not been a big issue in my practice. Another potential risk that exists for any form of hip surgery is dislocation of the hip. And this is the hip coming out of socket or the ball coming out of the socket joint. At least at the time that I'm making this tape, in close to 5 years of performing this procedure, I have no known dislocations.
Clinical update. I now have one late dislocation in almost 7 years of minimally invasive surgery and more than 500 procedures.
Also in that 5-year period, I have no known deep infections. A lot of people will also ask about leg length after the surgery. Now, it's certainly possible to change the length of the patient's leg by doing this type of surgery. I should say by doing hip surgery of any sort. Now, with the minimally invasive approach, radiographs are used during the course of the procedure, and so that the chance of there being a significant leg length discrepancy is really pretty small. Now, on a few occasions, on very rare occasions, I have selected to make the legs not quite match in leg length in favor of a stable hip. I'll make that trade-off every time, but still the vast majority of patients that I take care of will have leg lengths that are within about 3 millimeters. 3 millimeters isn't very far, and eventually, unless you take up marathon running, again, which I don't recommend, but with ordinary activities, 3 millimeters of leg length discrepancy is really not enough to tell. Now, I will promise you that immediately after the surgery, you're going to think that I made your leg an inch too long. This is because, in part, the process of arthritis makes the leg shorter. And when you start at the time of surgery, the cartilage is worn away, and sometimes some of the bone is worn away, and so the leg is shortened. Now, that process takes years and sometimes decades to develop. On the other hand, I bring the leg back out to its normal length over the course of 1 to 2 hours. This relative rate of change is something the muscles don't always appreciate, and so at least right off the bat, it will seem as if the leg is too long. But again, the vast majority of my patients have less than 3 millimeters of leg length discrepancy, and in the long run, nobody can tell that. A short while ago, a company called American Health Front surveyed the San Antonio area and tried to find physicians doing new and innovative procedures. At the time, I had been doing the hip replacement via 2 incisions for some time, and in fact, I'm the first in South Texas, South Louisiana to offer this minimally invasive approach. In any case, this roughly 2-minute presentation, I think, goes over a lot of the main features of minimally invasive surgery and its potential benefits. So please, let me show you the presentation from American Health Front.
The American Health Front is a presentation of Medical Media Group and the following physicians and healthcare organizations.
Today on the American Health Front, discover a new minimally invasive technique for total hip replacement, which uses only 2 incisions. We'll learn how patients with low back pain and leg pain can get relief with a less invasive treatment that's similar to having an injection. And come with us as we show you how advances in dentistry make it possible to change a smile like never before. Hello Hello everyone, I'm Ernie Bjorkman, and welcome to the American Health Front. The purpose of our program is to educate and inform you, the viewer, about treatment options now available in the ever-changing world of medicine. This is a special San Antonio edition of American Health Front. Our staff has teamed up with some of the area's finest physicians and healthcare facilities to explore the fascinating frontiers of today's healthcare, with reports on new techniques and technologies that could really change your life. So stay with us, because there is nothing more important than your health. An important goal for many people is to remain active long into their senior years. Thanks to developments in product technology and surgical techniques in orthopedic surgery, that goal is now often attainable. We take you to the office of orthopedic surgeon Dr. Adam Harris to learn about the new Zimmer, minimally invasive technique for total hip replacement.
The natural hip is a ball and socket joint. The ends of the bone are covered with a smooth, shock-absorbing surface known as cartilage. The arthritic hip has lost that cartilage and the surfaces resemble sandpaper. An artificial hip will replace both of the surfaces with bright, shiny, new, and now smooth surfaces.
About a year and a half ago, I developed severe pain in both hips, but the right hip was worse than the left, and it gradually got worse. I'm an ER physician, and got so bad that I could hardly go to a code because it hurt every time I took a step or when I'd stand on it.
When painful and debilitating joint disease of the hip is unresponsive to standard treatments, total hip replacement surgery may be your best option.
Traditional hip replacement surgery involves detaching or cutting into muscles in order to gain access to the joint. Then the surgeon must repair that damage on the way out. A lot of the pain after the surgery seems to come from either the damage done to the muscle or from the muscular tension on the repair.
Dr. Harris offers patients breakthrough procedures, which are minimally invasive joint replacements. Dr. Harris is the first orthopedic surgeon in South Texas to perform the Zimmer MIS 2-incision total hip replacement, and the first in San Antonio to perform the quadriceps sparing total knee replacement. Dr. Harris will now discuss the total hip replacement procedure.
Think about Venetian blinds. If the blinds are closed, it's very difficult to see out of the window. But you can put your fingers into the Venetian blinds, spread them apart, and see quite easily. And when you take your fingers out, the blinds fall back to their natural position undamaged. This surgery does very much the same thing with muscles. The surgery is done between the muscles or between the fibers of the muscle, so that when the instruments are removed, there's no damage to repair. I also apply the same minimally invasive concepts to knee replacement surgery with very similar results.
With this new technique, patients experience reduced recovery time and a rapid rehabilitation period. Let's learn more about the benefits.
Many patients will wake up from the surgery with less pain than they had before the surgery. Traditional hip replacement, on the other hand, will require 4 days or more in the hospital and usually a week or more stay in a rehabilitation facility. Crutches or walker may be needed for 6 weeks or more. With this surgery, the average stay is less than 2 nights, and people under 80 will almost always go directly home. Crutches or a walker might be used only for a few days.
I had a hip replacement, and I've been very happy since then. I've been able to walk without pain and to do anything I want. In fact, as I went back to riding a bicycle within a week afterwards and went back to work in a week.
This San Antonio edition of American Health Front is a production of Medical Media Group.
Last clinical update. I now use the direct anterior approach. The entire surgery is done between muscles, no fibers are split, the recovery is faster, the pain is less, and the function is better than the 2-incision approach.
Well, a new kind of hip replacement surgery is providing much-needed relief to patients with less pain and a shorter recovery time. Wendy Rigby has the story, new at 5.
For 54-year-old Josephine Dallaire, a simple, vigorous walk feels like victory. For 8 years, she had suffered with arthritis pain in her hip that impacted her every move.
Lying on my back would cause this throbbing pain. And then from there it went to getting up in the morning, just feeling achy, and then standing for long periods.
When she got her hip replacement in October, Josephine opted for a new technique called the tissue-sparing anterior approach. Orthopedic surgeon Dr. Adam Harris performed her operation at Methodist Stone Oak Hospital. He uses a special table that positions and holds the leg precisely, and then he works through one 3-inch incision. Unlike before, the surgeon does not have to detach or split muscles to get to the joint.
If you do not detach the muscles and you don't go through the muscles and you just pull them aside gently, then you're not doing damage to the hip as you're doing the procedure.
Since he doesn't have direct visualization of what he's doing, the surgeon uses X-ray throughout the 3-hour procedure to make sure his implant is perfect. Most patients spend a night or two in the hospital and are off crutches or a walker in 2 weeks.
It's very satisfying to see that patients do so well and do so well so quickly. And that's what medicine is all about.
I can wear a heel and I can walk hard. I can be at Home Depot all day or at the grocery store and no pain at all. To me, it's like a whole new me.
And Dr. Harris has performed this tissue-sparing surgery on about 200 patients over the past couple of years. He says he's had great success. Reporting live, Wendy Rigby, KENS 5, Eyewitness News.
Thank you very much for your time and for your attention. And I hope this tape has answered all of your questions. If you have any further questions, please don't hesitate to ask me. I'll do everything that I can to be sure that all of your questions are answered. Thank you very much.